Okay, guys, so we'll start with the test. I want to make sure that you guys all are aware. Once again, have your student ID, have or your driver's license or state ID. Same as last time. Gentlemen, if you're wearing a baseball cap, please put it backwards so we can see your face. One thing I noted last time is there was a lot of facial detection issues because a lot of you are going like that. So if it can't see your whole face, it will flag, which is fine. I mean, sometimes we do that, but it'll flag you for that. Make sure you're backlit, not front lit, because if you're too lit too much or it's too dark, it also can't recognize your face. At the end of the quiz, Dr. Karp suggested this, and I think it's a good idea. Please hold up your scrap paper and do another environmental scan. That way we know that you've been using your scratch paper, and that same thing though, do also send me a picture of your scratch paper. But yeah, if you can just hold up your paper to the camera, show me if you have multiple before you sign out and submit your exam. Other than that, everything's pretty much the same, guys. So, I need to give you the access code, obviously, for the quiz, because, it's kind of hard to take the quiz if you don't know how to get into it. So give me just... Okay. Typing in the access code, very original, guys. So the access code is just quiz 2. So make sure you log out of your, if you're using your device you're on right now to currently test, make sure you log out and then log back in. When you're done, come back here to the Teams. And of course, I will remain here in case there's any issues or problems. Anybody have any questions? All right, you guys. Well, Godspeed. Go ahead and log out and go take the quiz. And best of luck, everyone. Kristen and Davina, do you guys have any questions?
Professor Trainer, can you hear me?
Yes, I can.
So this is Davina.
Yeah.
I am having issues. I don't know what is going on. Like my whole tool, like the whole Respondus, it like froze.
Okay.
Should I should I delete the app and reinstall it? I don't really, it's like completely frozen.
Yeah, I would definitely do that
Okay.
for sure. And it doesn't show you as logged in yet, so you're okay.
Okay.
Okay?
Okay, thank you.
You're welcome.
Professor Trainer.
Yes.
So this is Davina again. I don't know what is going on. So I'm doing the webcam check, and it's like it's loading and it doesn't move forward. I don't know if it's something on my end that I'm doing. I have no idea what to do.
Okay.
I do have a laptop. I don't know if you want me to try it on my laptop. I'm on my iPad. I don't know what is going on.
Yeah, try it on the laptop. And you might have to update on the iPad or something because there might have been an update between last week and this week. So see if you can do on your laptop. Is the laptop just a regular PC? It's not an Apple product?
No, it's not an Apple product.
Okay. So then what you will do, Davina, you just need to go to the quiz and it'll download everything for you if it's not already there.
Oh, okay, perfect. Then I'll do that.
Okay.
Thank you.
All right.
Sorry.
You're welcome. Hi, Hayes. You're still muted.
Sorry, I'm having some technical difficulties this morning with my internet.
Okay.
Okay. What is the password so that I can get on there and get this going here?
It is just quiz 2, and I'm putting it in the chat there for you. All lowercase, all squished together.
Thank you, ma'am. Okay,
You're
I'll see you
welcome.
shortly.
Good luck.
Okay, sorry. Thank you.
You're welcome. Bye-bye.
Bye.
Hi, Tim. Hi, Kevin. So, welcome back, guys. You guys are some of the first. So if you could, you guys just want to take a break for a minute. It's probably going to be another 15 or 20 minutes until everyone's done. So I would say be back around 12:45-ish. Yes, Sade.
Can you hear me?
Yep.
On one of the questions, when you're asking for I think you're asking for teaspoons. How many teaspoons are in how many? I think it was 15 teaspoons into how many make it into tablespoons. I don't even know if I'm saying this right. I don't even know what I'm trying to ask.
Train of thought just went right out the window, huh?
Yeah, because I'm trying to think of the conversion factor you gave us. Oh, you only gave us one. I think you said 1 teaspoon equals 5 mLs.
Uh-huh.
And so we had to figure out how many teaspoons are in a tablespoon.
How many milliliters in a tablespoon?
I swear it said, okay, never mind.
15.
Okay, never mind.
You're welcome.
You'll see the math that I did, because I thought you're asking for tablespoons and not mLs.
That's all right.
Alrighty.
All right, everyone. We still have people taking the test. So those who have come back, you want to go ahead. You can take a break and step away until about 12:45, and then I'll see where we're at with the quizzes, and we'll go from there. Hi, Christina. If you want to go take a few moments to step away and take a deep breath, you can come back in about 12:45 and I'll see how many we still have left to finish. No worries, Shanae. No worries at all. Exactly. See, now that's the advantage of doing this online because you're taking the test. You can talk to yourself, sing to yourself all you want. Nobody else is going to hear you except me when I watch the video. However, if we were in the classroom, you probably wouldn't be doing that because everybody in the class would hear you. And for me, the fun part about giving tests is watching everybody's facial expression as they're trying to figure out answers and they're thinking and all that stuff. It's kind of fun to watch you guys, but I don't get to do that now. That's okay, Adriana. It's more of a recommendation, um, so that I can make sure that, we can see it. So we see your desk. Oh, Courtney, I'm sorry. I didn't want you to feel anxious. I was trying to help you make it a little bit better. But keep in mind, guys, don't worry about it. I know what you're doing. You know, even if you don't show me your scratch paper, but you email it to me and I can clearly see you were doing that. And then when you're on the screen, even if your head's bent down, I can hear you writing because your pen or pencil is scratching on the paper. So don't worry about it, guys, okay? Seriously. Um, I am here to advocate for you. So if need be, I mean, I review them all. Also, so if Professor Foster has any question about it, I'll be happy to step up and say. Now, that being said, doesn't mean I'm going to let you get away with if I think it's cheating. But thus far, you guys have been fine. I've watched the videos. It's not a big deal. And as I think it was Professor Nosik said the same thing, you can clearly hear when you're working out a math problem. So my email's blowing up with all your scratch papers. No, Veronica, we're just chit-chatting, waiting for everybody to come back. There's still quite a few who are out still taking the test. So if you guys want to take a few minutes, and at this point, I think we're looking at probably 1 o'clock. So if you want to step away for a minute and come back at 1 o'clock, you're more than welcome to. Again, if you guys forgot to scan your area after you were finished with the test, not a big deal. It's just a recommendation. It's not a rule. It's all right, Sean. You're not the only one, so that's okay. I know, I'm making faces. Hi, it's interesting that that's new for you guys though, because we've all are supposed to have been doing that um for a while now. Actually, pretty darn proud faces, Veronica, I'll tell you that. You guys are really knocking this out of the park. Then there's some I'm like, not sure how you got to that answer, but for the most part, you guys are really knocking it out of the park. Two, let's see, one. I only have 5 more left taking the quiz. Y'all are going to give me a complex, though. You're all missing the same questions. It's all right, guys. All right, so we're probably going to get started in about, hopefully the next 5 or 10 minutes. I'm going to step away for a minute, guys, because I need to use the restroom myself. So, you guys, if you haven't taken a break, get up and stretch. Check on the kiddos if you need to. Get yourself a snack, something to drink, preferably non-alcoholic. You can drink later. Anyways, anything else, just, go ahead and relax, and I will be back shortly.
Professor Trainer?
Yes.
Hi, I can't figure out how to message you and I can't find you on here, but it kicked me out in the middle of my test.
Really?
Yeah, it was answering question. I put in a number and then it said, thank you for your videos over. And I had like 15 minutes left.
Huh. Interesting. Usually it would only do that if you accidentally hit submit.
Yeah, I put in a number. I was putting in a number. So I don't know.
Okay, I'll look at that, Hayes, and then we can
That was frustrating.
so Hayes,
Yes.
you got through the entire test.
Oh, it said I had 15 minutes left and I had like 40 questions.
No, you have 40 minutes.
Okay. Oh, I was freaked out. Thank you.
No, you got through the whole thing.
Okay. I was thinking I had more questions. Well, good. Okay. Thank you.
No, you're fine. That's okay, Mercedes.
So I ended up like apologizing in the middle of my test because I like moved my scrap paper to like put it like in front of me, but it was like covering my face. I'm like, I didn't mean to do that.
That's all right, Natalie. I'm glad. Actually, I appreciate that you said something because then it'll be clear that you're like, oh God, I'm aware of what I'm doing.
So yeah, I apologize. I was like, I didn't mean to do that. Sorry.
It's all right. I'm sorry you guys are so freaked out about it because I really don't want you guys to be. That's okay, Hayes. Like I said, so long as I'm aware of what's going on, you're fine. All right, so it looks like everyone is done. Again, guys, I have to adjust, I have to adjust the quiz, and I'm going to take a look and see, because there were quite a few questions that I know we discussed in class, but that were missed. So I'm going to review those. I've already going pretty much, I think I've gone through almost everybody's for the math. And not necessarily the math, but if you didn't put the question the way the system, and I've got to fix this, because it will flag it as wrong if you didn't enter it exactly the way it was supposed to. So at any rate, I'll be going through that. For those who are like, oh, I forgot to scan my environment, that's okay. It happens, and it's a new thing for all of us. So no worries about it. As long as you sent me your scratch paper, I'm good. Christina, I honestly, I don't, because I know if you look at the question, the question will say blank and then it'll give the units. So that seems kind of redundant. The way it was set up in such a way that that is supposed to be put in the answer. And there's actually, I think there's one who got the right answer but put the wrong unit. So that I kind of maybe have to mark for. So yeah, if others didn't, I prefer that if they didn't have the units, then put the units. If they didn't, if they did, then that's fine too. So yeah, it's tough. I know, guys. So now that we are all, I'm not a real stickler on that, because if you just put in the if you just put in all the number, I know what you're talking about. So. No worries. I don't, like I said, I don't mark off for that. If you get the right answer, because most of the time the question is literally asking for blank in the units. So if you get the right answer, even though you don't put in the units, I'm okay. All right. So no worries on that. One more test out of the way. Yay. All right. So today we are going to go all over diabetes. You guys may have seen while you were taking the test, I uploaded a worksheet into the, or shared it into the chat. If we want to, if you guys want to utilize that to help you with lecture, and then we can kind of maybe go through it a little bit later. So today is all about diabetes. Yep, chapter 11 and then chapter 32 also in the other book. So today's all about the sugar diabetes. So we're going to go ahead and get started. Let me share my screen so you guys can see. Excuse me. And then if you want to, guys, you can, if some of you may have the hand raise feature, which is really nice. So if we can try and utilize that as much as possible. All right, so we're going to talk about testing and treatment for patients with type 1 and 2 diabetes, look-alike antidiabetics, insulins, the different insulins, and then evaluate glucose. And then picking the right syringe size, and then big safety issues related. So we've got oral and injectable that are non-insulin anti-diabetic agents. And you're like, wait, not injectable or injectable non-insulin. I thought it was all insulin. No, there actually are injectable non-insulin products like Byetta, which I think has been actually taken off the market. And then Victoza is the new latest and greatest one. And then there's Simlin, which I have not seen used a whole lot. Some of our orals, the classes, we have biguanides, which is the metformin, which is glucophage. You might have seen a lot. Meglitinides, which is Prandin or Starlix. And if you look, meglitinides, if you look at the end of the names, it's inide. Sulfonylureas that you will see a lot. And those are the rides, diabeta, emeril, glucotrol, DPP-4 inhibitors, Onglyza and Januvia. Not used a whole lot. Januvia is used some. And then the alpha glucidase inhibitors, which are Precose and Glycet. So, insulin is a very high alert medication, guys, okay? It has a higher than average potential to cause harm if it is used incorrectly. Doses are all individualized based on the patient, on frequent glucose testing, and there's a lot of the oral and injectable non-insulin medications are actually are a growing number of hypoglycemic agents. They target specific problems within glucose metabolism, and commonly they're used in patients with type 2 diabetes. So you're not going to see a lot of the orals in type 1. Simlin's about the only injectable outside of insulin that you will see used. So insulin has 3 forms. You have rapid onset forms, you have your intermediate acting, and then your longer acting. Remember, insulin is always subcutaneous. And you got to make sure you're carefully looking at the labels. So short or rapid acting, they treat your current level. So what is your blood sugar level right now as I test it? Or if you have an anticipated elevation in the near future, such as after a meal. So for instance, rapid acting, you may take your glucose and it's 435. Well, then you definitely want to give yourself rapid insulin to bring it down quickly. If, say, you're sitting down to lunch and you check your blood sugar, some people will adjust based on the carbs that they eat. So they'll give themselves rapid acting. Intermediate acting generally is given before breakfast or before meals. It can be it can be twice a day, so evening, morning. It could be given, you might have to give a bedtime snack if they drop too low. And the long acting, sorry guys. The long actings contain additives that actually cause it to be released more slowly. And it's given when the patient's blood glucose levels are unresponsive to intermediate acting. The long actings are generally given once a day, so you won't see them commonly given more than, sometimes they'll be given twice a day, but definitely most commonly one. So insulin comes in 2 concentrations. It comes in U100s or 100 units per milliliter, or U500, which is 500 units per milliliter. Now that is very, very, very rarely ordered because that's a lot of insulin, okay? So you'll see U500 right here. And then you also see here it says 500 units per milliliter. On the one on the left, you see U100. And then you also see 100 units per milliliter, okay? So U100 is not the total amount in the vial. It refers to the concentration per milliliter, okay? So again, it's the 100 units per ml. So as you can see on the left side here, the 100U, right above that, you see that 10 milliliter. And that's where you'll see, okay, there's 10 milliliters in here, and there's 100 units per each milliliter. The most common adverse reaction to insulin therapy is hypoglycemia, low blood sugars. When you are writing out an insulin dose and you want to write out units, or you want to use units, even though this says U100, do not use the abbreviation U. You must use units. When you're giving insulin, you want to make sure that you monitor their blood glucose frequently. And the timing of insulin administration and timing of the meals are actually linked to the onset of the insulin activity. So you can have hypoglycemia at any time, but the insulin onset and peak gives you close observation times for potential reaction. So say if an insulin peaked in 2 hours, you give the insulin, and in 2 hours, you want to make sure within 2 hours you're checking on that patient for hypoglycemia. Always, of course, consult the manufacturer's information regarding mixing insulins and oral antidiabetics. Rapid acting insulins mixed with longer, slower acting reduces fluctuation and elevations in glucose. And then intermediate and long acting insulins contain additives, so extend the action, but they are not suitable for IV. So the only insulin that you are going to use IV is regular or R insulin, and that's a rapid acting. So some of your insulins are listed here by category. So we have the short and the rapid actings. You have the short and intermediate actings, and then just straight intermediate acting, and then your longer acting. So your glargine and detamere, Solantis and levemir. So you have the generic, you have the brand name, you have the onset, the peak, and duration. So you know exactly how long it's going to last. Now, notice down here with the long acting, actually says do not mix with other insulins. So you are never actually going to mix with other insulin, or a long acting with other insulins. This is on, let me make sure. So this is table 11-1. At least I think it's table 11-1. Let me find it for you guys. Should be in here. Yep, it is. It's on page 391. Yes, Adriana.
I just have a quick question, and I'm sorry if other people know this, but I don't. But why would someone mix insulins? Like maybe because previously one didn't work and then...
No, so sometimes you might mix an insulin to help decrease the amount of sticks that a patient has to get. So again, if you do a rapid and a slower acting, you get less peaks and troughs, so less up and downs. It helps create a more steady baseline. And again, also not having to stick someone up, oh, here's your regular and then here's your other insulin. So you can mix them together and give it in one.
Got it. Thank you.
You're welcome. So, and the only other thing with the hand raising, guys, is you have to remember to take your hand down. Just FYI. So storing insulin, opened and unopened. Some say to refrigerate everything. Others say the current bottle can be at room temp. Unopened bottles have to be refrigerated. So always read the product labels for that storage information. Make sure you're checking expiration dates, though. And if you do open a bottle, make sure you put the date that the bottle was opened on the label. Usually they're good for about 30 days, or the expiration date, whichever comes first. Make sure if a client is traveling, if a patient is traveling and they have insulin, to keep it in a cooler. Do not tell them not to use dry ice, or carry it on his or her person. If it's warm, insulin can develop crystals and may become discolored, and then it won't be effective. Exactly, Hayes. Sometimes 28 days, 30 days. 28 days I know is standard in most facilities, but you can do up to 30 days. So it's good for a month, 28 days, 30 days within that. So usually within a month. So the short and rapid acting, they're usually given to treat a current elevation, or, as I said, an anticipated elevation. So after a meal or snack or anything like that. So short and rapid acting, you've got Humalog and Novolog, and that are usually given 10 to 15 minutes before a meal. Now, that being said, if the meal may be delayed, do not give a patient the insulin, okay? You don't want to, and honestly, in teaching my patients, I tell them not to take their diabetic medications until they're like sitting down to eat, because you never know what's supposed to happen. Or what might happen. So I had a patient once, I told her that she needed to be fasting for her blood work, and she ended up having to call an ambulance and going to the emergency room because she and her husband never stopped to think that perhaps she shouldn't take her oral anti-diabetic medication. So she didn't eat, and she waited hours and ended up with hypoglycemia. I think her blood sugar was like 29. So yeah. So really important also for yourself, and also to teach patients not to do their medications until they're sure they're going to eat. Oh yeah, they got really mad at me because I didn't tell them that. So don't assume that people know these things, guys. Better to assume that they don't know anything, and overteach than underteach. So Humalog should always be clear. Do not use insulin if there's any clumping or cloudiness, unless it's supposed to be cloudy. If the bottle has a frosty appearance, you're not going to use it. Always make sure you're following prescriber and agency policies. If there's a reaction, you will want to use some fast-acting dextrose or glucose to raise blood sugar. Usually, though, if you do that, you want to give them a more complex carbohydrate to help sustain the higher blood glucose. If you're treating a hypoglycemic episode, what happened during a hypoglycemic, you should take 15 to 20 grams of a simple carb, such as glucose tablets, glucose gel, a handful of raisins, 8 ounces of non-fat milk, hard candy, jelly bean, gumdrops. So 15 to 20 grams of a simple carb. Now, that being said, sometimes the glucose tablets, they can be kind of pricey, and insurance doesn't always cover that. My husband used to have hypoglycemic episodes, so I actually carried a very small tube of cake decorating frosting. I tried to get it in white, not the funky colors, otherwise his mouth would turn colors. So if he started feeling like he was getting a low blood sugar, just a little squirt in between his gum and his cheek, quickly dissolves and gets into the system. So that's another one if they don't have candies or glucose tablets. Then once you do that, you want to make sure you give them some sort of complex carbohydrate and protein snack, like peanut butter and crackers, or cheese, or crackers and half a sandwich, because you don't want to have a hypoglycemic rebound. So you use the fast-acting glucose, get it back up, but then they don't eat anything and it goes right back down again. Intermediate, usually received twice a day, once in the morning and once in the evening. They might have mixes Want to make sure they have a bedtime snack, like half a cheese sandwich or milk, to cover potential reaction. Mixes are usually prescribed by physicians for specific periods. Isophane insulin, which is abbreviated as NPH or N, is a modified insulin suspension. So it gives them that delayed basal release, so that base insulin. It has a longer duration than short acting, and the additives that extend the action make it cloudy, so it's not appropriate for IV. You either gently roll or gently shake. I always roll it between my hands to mix the ingredients. When you draw them up, an immediate acting insulin must be given right away. And depending on the preparation, the additives can extend the duration of coverage to up to 26 hours. So these are really pretty long acting. Now notice on here, you see this one says human insulin, and this one also says human insulin. Not all insulins are human. They're not all made from human hormones, or in this case, our DNA. Some of them are made from pork, or those kinds of things. So that's kind of important to take into account if you have a patient of particular religious affiliations. So long-acting, they're released more slowly. Patients should always be given a bedtime snack with longer acting, and these also cannot be given IV because of the additives. Long-acting can be administered to patients with type 1 or type 2, whose levels are unresponsive to intermediate acting. So patients who have early morning fasting. Yes, Alicia. That's why it's important to look at the labels, because they will tell you if they're porcine or made from a pig. It's always best to say, no. If you need to, you'll have to call the doctor and say, well, it depends on their allergic reaction to pork. So if they develop hives, then they may develop a rash, or it may be more severe than that because you're injecting it. Also, if they have anaphylaxis, then they would potentially go into anaphylaxis. Then, yeah, you would definitely not. I mean, nobody should be given it if they're allergic to pork, but you definitely shouldn't take insulin that is made from pig. Not a problem. Some people are kosher, so, kosher people don't eat pork. So, sorry, guys, I got a sunburn. My shoulders are itchy. All right, so back to long acting. So type 1 or type 2, with like patients who have an early morning fasting elevations, or patients who can't tolerate more than one injection a day. Again, you cannot mix long actings, and always assume that an insulin cannot be mixed unless you read otherwise, and make sure you're checking compatibility, because not all insulins can be mixed together. So glargine and detamir are clear products. They don't have really a peak. They give a steady release of insulin for 24 to 26 hours, and they are known more commonly as basal long-acting insulins. Now that's basal because they give a base. They can't be mixed, given at any hour, but must be given at the same time each day. So, for instance, if a patient is always giving their insulin at 9 a.m., they need to always give this insulin at 9 a.m. So they keep those set levels and every 24 hours. You can give a short-acting insulin if needed, but it does have to be in a separate syringe. You cannot mix it together. Always safe to make sure that insulins can't be, to assume they cannot be mixed. If you don't know, look it up. Okay. Also, anyone who's on a fast or intermediate acting or a long acting insulin, so basically anyone who's on an insulin should always have a bedtime snack. Okay, we talked about the additives given to patients who are not responsive to intermediate acting. So those will be people who have early morning fasting elevations or who can't or won't tolerate multiple injections. Unrepetitive, long-acting insulins cannot be given IV. Yes, Natalie.
For the, because I'm looking at the sheet that you printed out or gave us, did we cover the can suspension by administered intravenously in an emergency? Can a suspension? Number 4. I cannot talk today.
So a suspension would be something that has a liquid with particles in it.
Okay.
Does that help?
Yes.
Okay.
The answer is no.
That is correct. Very good. Yeah. So guys, that's question number 4 in that worksheet. A suspension is something that's suspending something in a liquid. So remember I said that we can only give regular. It doesn't have any additives suspended in it, so it can be given IV. But anything else all the other insulins have additives in a suspension, and so they cannot be given IV.
Thank you.
You're welcome. So steps to prepare doses. You want to make sure you're checking your blood sugar values, of course, because you'd really hate to give them something. And if their blood glucose is too low, according to the prescriber's instructions or the facility's policy, you definitely don't want to give them insulin. So you would hold the insulin and you would call the doctor for any directions if there aren't any instructions. Most of the time in facilities, if you're doing like you'll do a sliding scale. So their insulin dose will be based upon what their blood glucose level is. And there is specific parameters for when to call, but there's also specific parameters to treat. So if it's between, 50 and 60, you'll give XYZ snack or something. So make sure you're checking your order for the patient's name, the type of insulin, the dose, so the amount of units, the time, and this is route. The route for insulin is always going to be subcutaneous. Then make sure you're choosing the correct insulin syringe. Remember, we have U100 and U500. Very, 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 very rarely, like almost never, are you going to use the 500. It almost always will be 100. And then make sure the insulin syringe matches the units per milliliter on the bottle. So that'll be your clue. You'll look at the bottle, and if it says U100, you know you need to use a U100 syringe. If you're using an open bottle, make sure you look at the discard date and expiration date, which you should do with any multi-dose vial. Make sure you examine for any precipitate. If it's a suspension, so an intermediate or not the rapid, but short acting, you may have to roll it. Make sure when you're drawing up, you're going to draw back the amount of air units to create a vacuum. So you're going to exchange the air. So if it says 2 units, I'm going to draw back 2 units on the syringe. I'm going to inject that air to the vial, and I'm going to it'll pull out with just a vacuum. So insulin may have precipitate if it gets too warm, if the vial gets contaminated, or if it's past the expiration date. Rough shaking the insulin vial causes air bubbles, which actually alter your dose. So don't shake the vials. You really don't need to do any calculations for single insulin injections. And some agencies will require 2 nurses for the entire preparation, and they have to co-sign the medication. So that means that if Sean is drawing up an insulin and he's drawing up 3 units, he's coming to me and he's going to say, Professor Trainer, I'm drawing up 3 units of regular insulin. I'm going to look at the order and see that it is 3 units of regular insulin. I'm then going to look at the medication administration sheet and verify that the order is there. And then I'm going to also look at his syringe and verify that he only drew up 3 units. And that will happen anytime that you draw up insulin. So, obtain and interpret blood glucose, read the order, select appropriate insulin type. Kind of just went through all of this. Sliding scale. This is what you're guys are gonna commonly see in facilities. They're usually ordered for every 6 hours in hospital patients, patients who are on tube feedings, or patients who are on TPN, that total parenteral nutrition. They are usually ordered. If the patient is eating meals, they'll be ordered AC and bedtime and HS. So that's. And that means before meals and at bedtime. And that will cover your meal and bedtime elevations. And the insulin dose slides or changes depending on their glucose level. Usually it's kind of customized. And usually you'll see and this is how you can see a great pattern. So if you're looking here at the sliding scale, it's every 6 hours. They're on Humulin R, so it's rapid acting. Okay. If their blood sugar is 70 to 50, they get 0 units, 150, sorry. If it's 151 to 204, and so on and so forth. Now, when you get down to 301, 350, 351, 400, you see that you're supposed to give units and then recheck 1 hour after you administer it. And then anything over 400, you're going to call the physician and get a plasma glucose. That's a lab draw, guys. So what I would do in that situation, my patient's blood sugar comes back where I say 435. I'm immediately going to put in a stat lab draw for a plasma blood glucose for glucose level so that the lab will come up and draw that, because capillary versus venous is not always the same. And I'm going to call the physician and I'm going to say, Dr. Smith, I just checked finger stick on Mrs. Jones and her blood sugar was 435. I'm awaiting the results. Now, that being said, sometimes, and you'll learn these physicians, it's better to just wait until you get the results back before you even call. Okay. And that's why you would order it stat. So you're going to get the results sooner rather than later. So, you might have a sliding scale bolus along with your basal insulin. Brittle diabetic is someone who is very poorly controlled despite their insulin therapy. So they're really just all over the map. The patient, well, I'm not going to have the patient do self-monitoring of blood glucose in the facility. You're going to recheck very high or low levels with a different monitoring device before actually acting. So if you get something that's 435, I'll check it on one machine. And and I get the 435, and then I'm going to go get a different glucometer and check it again. If it's still 435, then I'm going to get that stat glucose level. Make sure you check your insulin bottles. Ensure the bottle is supposed to be clear or cloudy. So one thing to keep in mind that there are some times where a hospitalized patient will be self-administering their insulin and has all these unexplainable elevations. And we're actually finally found discarding the insulin. So make sure if they're self-administering, you're watching them give it. In the hospital though, guys, generally, no, patient's not going to give it to themselves. And if in the rare case they do, you need to monitor them. Sliding scales titrated every 6 hours, ACHS. Every 6 hours will be anyone on TPN, NPO. There's usually a mild, intermediate, and aggressive sliding scale. And obviously 3 to 4 times a day you're going to check. Here's another example of, well, actually it's pretty much the same example. So interpreting sliding scale orders. You have Lispro insulin subcutaneous ACHS per the sliding scale. Okay. The morning glucose is 255. So in this case, you see here, 251 to 300, they're going to be given 10 units. Make sense? Sorry, guys. I keep my afternoon siesta time. I don't know about you guys, but holy cow. All right, so short and intermediate combinations. So mixed insulins give coverage for meals with a small amount of short acting, and they have slow release intermediate acting. So usually there's a rapid and a slow acting insulin combined together, and so you might see 70-30. If the order is for 10 units, 7 of those units or 70% will be NPH, which is the intermediate, and then 3 of those units would contain the fast acting. So that's kind of where you get 70-30 out of 100. Mixed insulins are usually taken twice a day, the specific number of minutes before the meal and evening. So 30 minutes, 60 minutes. And each injection will cover 2 meals or 1 meal and the bedtime snack, depending on. So here, the first number is the percentage of slower. The second is the percentage of rapid acting. Okay. And then here is your order. 18 units, sub-Q, 30 minutes. AC is kind of redundant, but before breakfast and dinner. So matching insulin concentration and syringes. Again, remember U100, you want to use a syringe calibrated to 100 units per milliliter. Only use an insulin syringe when you're preparing your insulins. Never, ever, 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 ever use a regular syringe. Only use insulin syringes. Now, the insulin may be 100 units, but it's going to vary in capacity. Okay, so you may have 30 unit, 50 unit, and you can have up to 100 unit. It's still kind of a one-to-one thing though. And the markings can come as even or odd in the number calibration. So hang on, guys. All right. So here you go. So on the left to right, this is a 3 unit per 10 in 10 ml, so 30 units. Okay. Syringe with half unit markings. So 5, 6, 7, 8, 9, 10. Okay. 11, 12, 13, 14, 15. Then this one has whole marking units. It's also a 3 and 10. And then we have the half milliliter, which is 50 units. So this is a half, it's 50 units. Remember, for unit 100, U100 is 100 units per milliliter. Well, this is only 50 milliliters, which is half of 100. And then 1 milliliter per, oh, look, it says the book even put CCs. Guys, shame on the book. And this is 100 units. So depending on the amount of insulin your patient needs, it depends on how much you will actually give. Don't confuse these, though, with a tuberculosis syringe, which can be done. So sites for injecting your insulin, remember, it has to be sub-Q, so it has to be a fatty area. So the abdomen, a 2-inch radius away from the umbilicus or umbilicus, in your thigh, generally on the outer aspect here. You can also do the fatty part of the upper arm, generally on the back side of the upper arm. And then, of course, fatty tissue on the buttocks, which is the upper part. Occasionally, you have to mix. So you're going to slow release or intermediate acting, mixing with a regular. This can be used twice a day to help give what we call Adriana.
Just a totally random question. If it was given intramuscularly rather than sub-Q, what would, like, because the metabolism or distribution, how would that be affected? Does that ever happen?
It's rare that that's ever going to happen because of the use of insulin syringes, which already have needles on them. So the needles themselves aren't going to allow you to go that far in.
That deep. Right. I'm just curious, like, if it's ever, like, what would happen? I don't know.
You would have it wouldn't be as efficacious,
Okay.
and you wouldn't see it working as well because it or going through the muscles
slower.
would make it different.
Okay, thank you.
That's a good question, though, because you know, it's a thought, but generally, guys, you have specific insulin syringes and they have specific needles on them, so you're not going to end up with having that issue. Okay, common combinations you're going to see in mixes is a regular and an intermediate acting, and always make sure you double check your order and also double check the compatibility. So in this one, you see Humulin R, which is a rapid acting, and Humulin N, which is a longer acting, and you're going to mix these. So you have 6 units of rapid and 20 units of Humulin N. So you're going to end up in its subcut or sub-Q. This is a really weird expression of sub-Q. Twice a day, AM and PM, so in the morning and night, 30 minutes before a meal. So the total dose of insulin that you're going to give is 26 units. Make sure you check for compatibility. Being as they're both Humulin, I'm pretty sure they're compatible. But don't confuse Humulin with Humalog. Okay. Humalog is a rapid acting insulin, so you really don't want to get those confused. So how do you prepare insulin mixes? So make sure you identify your vials, check your order. Don't shake. I'm not going to tell you guys. I'm just going to say don't shake. Let's just not shake insulin vials. Let's roll them between our hands. And then make sure you're cleaning the tops of the vials with alcohol swabs if they've already been opened. If they have not been opened and you're popping them open for the first time, you don't really need to worry about cleaning it. If it makes you feel better, go ahead and do that. Otherwise, don't worry. Also, when you're identifying the vials, make sure that you are looking for the expiration date and the date opened if the vial's already been open. And then we're going to insert the air equal to the amount you need, and that's to create the vacuum. You're going to start with the intermediate acting and go to the short acting. The reason why So you're going to inject air into the intermediate acting, then inject air into the short acting and draw that out, and then go back to the intermediate acting and draw that. Because the intermediate acting, it's not, if you put intermediate acting in the short acting vial accidentally, then you've messed up the whole short acting vial. But there is some in the intermediate acting. There is a little bit, there is some short acting, so it's not as bad. So like I said, withdraw the clear short acting and then verify the correct amount. And then you're going to do the intermediate acting. Make sure you tap out any air bubbles and make sure you have the correct amount. And then if you do it wrong, discard it. Yes, Veronica. Yes, short means fast acting. So, your sequence. Remember, cloudy is the intermediate, clear is the short or more rapid acting. So, step 1, you're going to put air into the cloudy. Step 2, you're going to put air into the clear. Then you're going to withdraw the clear and then the cloudy. Okay, so this is literally step by step, guys. Circle, highlight, whatever you need to do. These are the steps. Always, always, always draw clear to cloudy. And what insulin, guys, does not mix with any insulins at all? Exactly, long acting. Never, ever, ever mix your long acting. Okay, so IV insulins, they can be used in the hospital. Most likely you're going to see these in ICU. You might see them on some medical surgical units after patients been stabilized. So patients who are coming in with astronomically high glucose levels will be put on an insulin drip. Their glucoses are going to have to be monitored very frequently. You are going to use regular or Humalog insulin. And generally, you're going to get a 50 unit in a 100 milliliter bag of so you have normal saline, and it'll have 50 units in that 100 milliliters. So IV insulin actually has may have 0.5 units per ml. It could be 100 and 100. So make sure you know the ratio in the IV bag. Insulin should always be given on its own separate line via a pump. You need to make sure that that IV is labeled with the concentration on it. So 100 units per 100 ml, so 1:1, or half a unit per ml, so that you know what you're supposed to, everybody knows what is in that bag. So usually the order is going to tell you how many units per hour you're going to infuse it. So you're going to have to, you may have to figure out with the concentration, the flow rate. Now, if it's 3 units an hour and there's 100 units per ml, or it's 1:1, then you know it's going to be 3 milliliters per hour. Whoops. If it's a 0.5 per 1, then you're going to actually double the milliliters per hour because it's half. Okay. So you have Humulin R insulin at 3 units per hour, and it's available at 100 units and 100 ml. Estimate the flow rate. So when we say estimate, guys, I want you to stop and go, okay, well, what do I think the flow rate's going to be? Okay, that's where you estimate. and then ordered it. Show me the equation. And you can see right here, you've got 100 milliliters per 100 units times 3 units because we want milliliters per hour, right? So this is how you would set up a simple a dimensional analysis equation to figure out. So if this was 0.5 units, or 50 units per 100 mLs, it'd be no, that wouldn't be. Yeah, that's right. 50 units per 100 mLs would be the 6. So make sure you're using a pump. There's going to be orders for how often to monitor. Report any highs and lows and unusual changes as soon as possible. Make sure you have glucagon or injectable 50% dextrose on hand as much as possible. So other devices you might see are pre-filled pens. They can have regular, they can have intermediate, and they might have a mix. They have single-use finer needles, so the patient has to put the needle on every time. And gauge 30, 31, or 33 gauge, so very, very, very fine. These are great for people who don't have good vision because the numbers are so much easier to see on one of these syringes versus on or the flex pens as opposed to the syringe. And then, of course, the dial is easier for people whose hands don't work as well. Usually there's about 300 units in a pen. And the window gives you an idea of how many units remain. And they don't have to prepare their own insulin in a syringe. They just dial it to how many units they're supposed to have. So this is the dial right here that shows how many units they need. They dial it up to 1. They have their needle on. They put it up against their arm. They press this button and it injects. Awesome. Love the pens. Other pens that you'll see Apidra, Byetta, Victoza, Humalog Quick Pen, Humulin, Lantus Solo Star, and the Levomir Flex Pen. Those are the longer acting insulins. Novolog Mix, NovoPen Junior, AutoPen. Ones that you're going to see more commonly might be Humalog, Humulin, Lantus, and Levomir. Insulin pumps. So patients might have an insulin pump if they're not responsive to intermittent injection. So if they're still very difficult to control. If they need more frequent insulin, they have implantable pumps and they also have portable. They give a programmed continuous basal or low rate continuous rate, a fast acting, and then they can also bolus themselves. So only short acting insulins are given through an insulin pump. It requires frequent blood sugar monitoring. I've had patients take their blood sugars anywhere from 8 to 12 times a day with an insulin pump, but they can be very, very easily controlled. And there are now the monitoring devices on the market that they can put on their arm, and it sends their continuous blood glucose. And this makes it very easy to adjust. And the patient can adjust their own pump. So with the appropriate teaching. So that's really, really a neat thing. All right. So that got us through chapter 11. Let's take a quick, about 7-minute break. So let's be back at 2:10. And we will get into chapter 32. Excuse me. Okay. Now, we talked about how to give insulin. Now, what do we know about insulin or anti-diabetic meds in general? So, function of the pancreas, signs and symptoms, type 1, type 2, things that can influence blood glucose, and how to manage, mechanism of action, developing a care plan. So diabetes isn't really a single disease, but it's a group of progressive diseases. It's actually a disorder of carbohydrate metabolism, and it can either involve either a deficiency of insulin, so not enough, or the tissue is resistant to insulin, or it can be actually a combo of both. So they believe that it is a result from destruction of the beta cells in the pancreas where insulin is produced. When insulin receptors are defective, they no longer respond to insulin molecules. So serum insulin and glucose levels are both elevated. They don't respond and transport glucose into the cells where it's needed. So glucose remains in the blood rather than being used in the cell or stored in tissue. So, diagnostic criteria for diabetes. Fasting plasma glucose higher than 126 milligrams per deciliter. Okay. Or a hemoglobin A1C, or A1C as we often call it, greater than or equal to 6.5. There are a lot of long-term microvascular and macrovascular complications related to uncontrolled blood sugars. Macrovascular complications are usually secondary to large vessel damage caused by atherosclerotic plaque. And microvascular are secondary to complications due to damage of the capillary vessels. So that's peripheral circulation. Autonomic and somatic nerve damage occurs. So type 1 used to be known as A1C. Anything greater than or equal to 6.5 is considered diabetic. So type 1 used to be known as insulin-dependent diabetes, or also juvenile onset. And then type 2 was known as non-insulin dependent or adult onset. Now that's a misnomer because we do know that sometimes in type 2 you have to treat people with insulin. And actually 10% of patients with type 2 diabetes actually have antibodies that actually suggest an autoimmune origin for diabetes, which is called latent autoimmune diabetes in adults. Or LADA. Actually, it's a more slowly progressing type 1. Now, if you want to look specifically at the differences between type 1 and type 2, you're going to look at page 502 and 502. Table 32-2. Well, that gives you like the differences and characteristics of each. Signs and symptoms. As we talked about, elevated fasting glucose greater than 126, A1C greater than or equal to 6.5, polyuria, so urinating excessively, polydipsia or excessive thirst, polyphagia, excessive hunger. Glucoseuria is glucose in the urine. They may have unexplained weight loss, fatigue, and blurred vision. Type 1, so they don't produce insulin or it's defective. So think of it as a lock and a key, and insulin is the key. And your cells have the lock on them. You either aren't producing enough insulin to unlock the cells so the glucose can get in, or the keys don't fit right into the lock to let the glucose in. So then patients need exogenous or external insulin. It's replacing insulin that either they're not making or that's not made correctly. Endogenous insulin is the insulin that your body makes. So some complications are DKA or diabetic ketoacidosis, or HHS, which is hyperosmolar hyperglycemic syndrome. And they are very different, and we'll actually talk about those. So acute complications. Let me see. Wow. So hyperglycemia, of course, is going to be a common one because obviously you're going to get high blood sugars. Ketones in the serum, acidosis, otherwise diabetic ketoacidosis, dehydration, electrolyte imbalances, and about 25 to 30% of patients with newly diagnosed type 1 present with DKA. And then HHS. So the comparison of DKA and HHS is on page 503, table 32-3. So for instance, when I worked in ICU, when I was working in North Las Vegas years ago, we actually, within 1 week, had 2 young Black men come in. One was 16 and the other one was like 19 or 20. Both of them came in DKA. Both of them, one of them had a blood sugar of 700 and something, and the other one was over 1,000. They both ended up in the ICU. They both ended up on insulin drips. We were treating them both. One of them did not make it. The other one did. And this was the first and only time, the first time either one, the patient or the family had known that they even had diabetes. So that's commonly, patients may not know they have diabetes until they present with DKA. And there's that table 32-3 that I was talking about. Usually DKA is going to be seen in the younger people. Symptoms ranges is different. Serum bicarb level, you'll notice, is different. In DKA, it's going to be low. And in HHS, it'll be normal. pH, obviously, will be different. Osmolality is opposite. The pancreas. So there are 2 hormones produced by the pancreas, insulin and glucagon, and both regulate glucose control in the body. So glucose is one of the primary sources of energy for the cells in the body. And when glucose amounts are sufficient, it is stored as glycogen in the liver and also in skeletal muscle. It can also be stored in adipose tissue, such as triglyceride body fat, which is why people with high triglycerides have a propensity to become diabetic. When more circulating glucose is needed, the glycogen is converted back to glucose, and that is called glycogenolysis. And glucagon is what's responsible for starting the glycogenolysis. So pancreas produces insulin and glucagon to regulate glucose, and then excess glucose stored in the liver or skeletal muscle tissues. Without insulin, your glucose levels rise, and when the kidneys can't reabsorb that extra glucose, they excrete it in your urine. They also excrete ketones and other solutes. So that's when you're going to see glucosuria, because they're going to be, the kidneys can't keep up. They're going to lose nutrient energy sources, leading to polyphagia, so excessive eating to try and make up for the energy loss, weight loss, and malnutrition. And then with solutes in the renal tubules and collecting ducts, that draws in a lot of water into the urine. So that can lead to excessive urination, dehydration, and excessive thirst. Type 2 is the most common type of diabetes. It's caused by an insulin deficiency, so they're not producing enough, and insulin resistance. A lot of tissues become resistant to insulin. Either you don't have enough insulin receptors, or the insulin receptors aren't responsive. So remember the lock and key. There's not enough locks for all the keys, or the locks and the keys don't fit together. So a patient with type 2 diabetes can have normal or even slightly elevated levels of insulin, yet high blood glucose, because they're producing the insulin, but the body is not using it all. Other conditions that may go along with diabetes: obesity is common. Coronary heart disease because of the macrovascular complications. Dyslipidemia, which is an elevation in the plasma cholesterol, triglycerides, or both. Dyslipidemia might be genetic, or it could be secondary. Hypertension, again, because of sclerosis in the blood vessels. Microalbuminemia, so protein in the urine. And they're also at risk for blood clots. So all of these together are actually called metabolic syndrome, insulin resistance syndrome, or syndrome X. Major complications talk about macrovascular, so coronary arteries, cerebral arteries, and peripheral vessels. And then the microvascular is damage to the capillaries. So that's where you develop the retinopathy, neuropathy, and nephropathy. And that you can actually find a table of this on page 501, table 32-1. So coronary arteries, you can have an MI, a heart attack. The cerebral arteries, you're talking about stroke. Peripheral vascular, you may end up with amputations or ulcers. Retinopathy, of course, damage to the retina can cause blindness. Neuropathy, very uncomfortable damage to the autonomic and somatic nerves. And that can also lead to amputation. And then nephropathy, we're talking about kidney damage because of the protein in the urine that damages the cells in the kidneys, and that causes dysfunction. And you can go all the way to the point where the kidneys fail. Gestational diabetes, a lot of these people, they're obviously pregnant women who develop diabetes. They may be well controlled on diet, but they might need insulin to help decrease risk of birth defects. Hypoglycemia in the newborn, and then also high birth weight. So pregnant women get blood glucose screenings. They'll often do a urine. And then they'll also usually have a glucose tolerance test. If a woman has gestational diabetes, she is at higher risk for developing type 2 diabetes later in life. So how do we screen? Well, they talk about pre-diabetes. I personally am not thinking pre-diabetes. I say at risk for, but we'll go with pre-diabetes. So anyone who's at increased risk. So A1C 5.7 to 6.4, fasting glucose greater than or equal to 100, but less than 126. And then anyone who has an impaired glucose tolerance test. So a glucose tolerance test is when they're actually given glucose and then you check their blood sugars at regular intervals. If it's above certain levels, then it is considered positive. Yes, Veronica, the orange drink. Most women hate it, and a lot of women puke. All right, so you have a woman who has type 2 diabetes, and she's pregnant. She wants to know whether to take her oral anti-diabetic medication. What instructions will she receive? A, she should continue. B, dosage will be increased gradually. C, switch to insulin while she is pregnant. Or D, she will not receive any anti-diabetic medication while pregnant and will monitor her diet intake closely. So actually, guys, the answer is C. A pregnant woman will be switched to insulin. A lot of the oral anti-diabetic medications, so this was kind of a tricky one on me. A lot of the oral anti-diabetic medications their pregnancy category is not acceptable. But insulin is naturally found in the body, so giving them insulin is acceptable. So pregnant women will always receive insulin therapy. Because there's just not enough information about, I know, sneaky, about oral medications. Non-pharmacologic treatments. Type 1 diabetics always require insulin because they don't make insulin. Their bodies don't use it. They don't make it. Type 2, however, you might be able to control or even become not diabetic. Yes, that is true. You can reverse diabetes if you're type 2. Weight loss, improving their diet habits, not smoking, alcohol. Alcohol is full of sugar. And then regular exercise. All those things can be done non-pharmacological, and that's usually where you start. And you'd like your patients, even if they have to go on orals, to even use non-pharm interventions if possible. So the glycemic goal of treatment is an A1C less than 7. Or a fasting blood glucose 80 to 130. Or you can look at an estimated average glucose, which is an EAG. But I don't really use that. A lot of times the A1C will come with an EAG, so it'll tell you what their average glucose is. Anyone who's less than 7 is controlled diabetic. 6.5 to less than 7. If they go below that 6.5, they're fine. And then also 80 to 130. A1C is done every 2 to 3 months. And the reason for that is because the hemoglobin is found on the red blood cells. And the red blood cells live for up 2 to 3 months. So that is why you will do an A1C every 2 to 3 months. And it doesn't matter if they're fasting or not. An A1C doesn't change because it's a percentage of the average. So treatment, of course, insulin therapy for type 1. Type 2, we talked about the non-pharm, so the lifestyle changes, oral drugs, and then, of course, if you needed insulin when you can't control with other medications. Insulin's oral hypoglycemics aim to produce normal. There are new injectables. So we want to make patients normal glycemic. Insulins, they're a substitute for our normal insulin. They create the same effects as your normal body insulin. And they actually help restore the ability to metabolize carbs, fats, proteins, store glucose, and convert glucose. Human insulin, you'll see I talked a little about, it's from recombinant DNA, or that rDNA. It's produced by bacteria and yeast, and it's helped to decrease the long-term incidence of complications. So human-based products, the ones that are going to be human insulins, are, you can see actually on page 505. So the only rapid acting that is human is Lispro, Lispro. Short acting ones, you have regular, Humulin R, and Novolin R. And then the only long acting human insulin is Glargine or Lantus. And these are where you always want to test before. So rapid acting is Lispro. Short acting is regular, Humulin R, Novolin R, and then the long acting is Glargine, also known as Lantus. Rapid actings, most rapid onset is 5 to 15 minutes, peak in 1 to 2 hours. Patient must eat after they get an injection. Humalog is very similar to endogenous. Apidra is another one you can use. Can be given sub-Q or sub-Q pump. You also have Afrezza. Afrezza is given as a inhaler. With a patient who uses the Afrezza inhaler, they must not have any chronic lung disease. So no chronic bronchitis, emphysema, COPD, none of that. And then we've got our rapid acting insulins. I got a weird order. These can be given IV, even given IM. Onset of the short acting will be 30 to 60 minutes, peak in about 2.5 hours, and only last about 6 to 10 hours. Regular insulin is the only insulin that is classified as a short acting insulin. Intermediate, NPH is the only available intermediate acting insulin product. This is going to be cloudy, guys. And remember, see, it says rDNA origin. Often can be combined with regular insulin. Onset in 1 to 2 hours, peak in 4 to 8, and last 10 to 18 hours. Long acting, we have the Glargine or Lantus. It's clear. Usually once a day. It gives you constant levels every 12 hours. It can be dosed every 12 for patients that are poorly controlled. Onset in 1 to 2 hours. Doesn't have a peak, so that's nice. And the duration is up to 24 hours. And then you have your Detamir, which is also called Levemir. It could be classified as an intermediate since it's given twice a day, but it is considered a long acting. So glargine, which is the Lantus, and Detamir are not interchangeable. So this is not interchangeable with glargine insulin. Little comparison of pharmacokinetics of the various insulins. You see the different peaks and then the durations. All right, you just gave the morning dose of a patient's Lispro Humalog insulin. After the injection, the dietary department calls to inform the patient care unit that breakfast trays are 45 minutes late. What do? A, inform the patient. B, check the patient's blood glucose. C, call the dietary department to send a tray immediately. Or D, get the patient food such as cereals and skim milk and juice. Oh, good job, guys. You guys are starting to think right, too, because I know a lot of you would be like, well, you need to tell the patient and call dietary. The most important thing to do is make sure the patient gets something to eat, and you guys are thinking like that, so that's awesome. Then we have the fixed combos, like we talked about, the 70-30, there's a 50-50, there's a 75-25. Sometimes a lot of patients take a rapid acting and an intermediate acting. So in order, like I said, to cut down on the amount of glucose or insulin injections, they've made these mixes, which make it much easier for the patient. There's always two different insulins. So there's in a fixed set combination. So 70% intermediate, 30% rapid. Okay. Or short acting. Sliding scale, we talked about, usually given in hospitalized patients. Even if a patient's on oral antidiabetics, they may have a sliding scale because they want to make sure that they control their blood sugars, because that can, diabetes can delay healing. Basal bolus, so they get a basal insulin or a long acting, and then a bolus with meals. And this actually is kind of like what the pancreas normally would do, because it'll give a continuous level of insulin, and then when it gets that shock of food, it'll actually bolus. So it actually totally mimics the way people are eating. Now, if a patient's NPO, you don't want to have them on a basal bolus insulin, because they're not going to eat. Oral antidiabetics, they're generally, type 2. Need to make sure patients can monitor their glucose. They may be on one or more drugs. And there's, you also want to treat any comorbid conditions like high cholesterol or high blood pressure. Alone or in combination, and also, of course, lifestyle changes is always a given with your patients who are diabetic. We have Diabetes Association guidelines. So new onset type 2, you want to start with the lifestyle interventions. Usually you're going to start with biguanide, so you're going to start with metformin. And then if you do lifestyle modifications and the maximum amounts of metformin and A1C is not controlled in 3 to 6 months, then you're going to add the second medication. Oops. Where am I? There we go. Okay, so biguanides, metformin, also known as glucophage, is first line, and it's the most commonly used. So its mechanism of action is it decreases glucose, right, Natalie? Decreases glucose production by the liver. So the liver isn't producing as much insulin. And it also decreases intestinal absorption of glucose and improves insulin receptor sensitivity. That way you have more peripheral glucose uptake and decreased hepatic function of triglycerides and cholesterol, which will also help with any hyperlipidemia. It also does not have, nice thing about metformin, there's no weight gain generally with it. And there's also not a lot of hypoglycemia or low blood sugars when it's used by itself. There we go. Decreased production of glucose in the liver, decreased intestinal uptake, absorption, increased uptake of glucose by the tissues. So most of the side effects are GI, like abdominal bloating, nausea, cramping, diarrhea, and feeling of fullness. A lot of those subside after a couple of weeks on the metformin therapy. They might also have metallic taste or decreased B12. Lactic acidosis is rare but can be lethal. And again, they don't cause a lot of hypoglycemia, which is so nice. Interactions, the drug interactions are actually on table 32-5 on page 505. Talks about insulin and what it interacts with, and then metformin and also glipizide. So metformin might interact with cimetidine, diuretics, so any medication that increases urine production, corticosteroids, and of course contrast media. So that's an important point, guys. If a patient is on metformin or glucophage and they're having any kind of imaging that requires contrast, they have to stop taking their medication for 48 to 72 hours before the test. Others, we have sulfonylureas. These are the second generation ones, are glimepiride or amylyl glipizide, which is glucotrol, and glyburide, which is diabeta. It can be used in conjunction with metformin. They should not be used in patients with advanced diabetes dependent on insulin. Once you start insulin, this medication is stopped. It's contraindicated, of course, in hypoglycemia or any conditions that might predispose to hypoglycemia. So reduced calorie and NPO, alcohol use, or older age. And there can be a cross allergy for patients who are allergic to sulfa antibiotics, which kind of makes sense because this is sulfonylureas. Again, drug interactions are seen on page 505, table 32-5. So again, beta blockers, cimetidine, erythromycin, fluconazole, sulfonamides, DPP-4 inhibitors, garlic, ginger, ginseng. There's their whole list there. So their mechanism of action, they stimulate insulin secretion. You must have productive beta cells. If the beta cells aren't functioning, sulfonylurea is not going to work. And it also helps improve sensitivity to insulin, resulting in lower blood sugars. Then we have the glinides and the thiazolidinino. Yeah, that one. So we're talking like Prandin or Starlix, not commonly used. And then like the glitazones, like pioglitazone or rosiglitazone, so Actos or Avandia. Avandia is off the market. And these are insulin sensitizing drugs, and they're used in type 2. Glinides are similar to sulfonylureas. They increase insulin secretion from the pancreas. They also have a shorter duration of action and have to be given with each meal. Type 2 diabetes can be used with metformin and thiazolidinides, but not with sulfonylureas because obviously they're the same. Contraindications and interactions are the same or similar to sulfonylureas. That's how I feel right now, Hayes. Sulfonylureas, so side effects, hypoglycemia. That's true of every antidiabetic. Sulfonylureas can cause hematologic problems, nausea, epigastric fullness, heartburn, weight gain. And then with the glinides, you've got your headaches, hypoglycemia, upper respiratory infection, weight gain also. Thiazolidinones decrease insulin resistance, so they're insulin sensitizing. They decrease insulin resistance by enhancing sensitivity of insulin receptors. They directly stimulate peripheral glucose uptake and storage and inhibit production of glucose and triglycerides in the liver. They have a very slow onset over several weeks, and max activity may not be seen for several months. Although they have seen some preservation of beta cell function, so it looks like it might slow. That's fine, Hayes. I figured it was either a kid or an animal. Slow the progression. It does have a synergistic effect with metformin and sulfonylureas. And then Actose can actually be used with insulin. Alpha glucodase inhibitors. Another one. Mechanism of action, it's not very commonly used, and they reversibly inhibit alpha glucodase, an enzyme that's in the small intestine, and that causes hydrolysis of oligosaccharides and disaccharides. When you block the enzyme, glucose absorption is delayed. Usually used in combo with another oral hypoglycemic. Contraindicated due to the adverse GI side effects. Not recommended in patients with inflammatory bowel, malabsorption syndrome, or of course intestinal obstruction. And they can interact with digoxin, ranitidine, and propranolol. The thiazolidinidines. So side effects of the thiazolidinides, hepatic toxicity, so liver issues, weight gain, edema, anemia, and the alpha glucosidase inhibitors can cause gas, flatulence, diarrhea, abdominal pain. Then we have your DPP-4 inhibitors of the gliptins, so Januvia, Anglyza, Tradjenta. They work by delaying the breakdown of incretin hormones by inhibiting DPP-4, hence DPP-4 inhibitors. And so incretin hormones are released throughout the day, and the incretin hormones increase insulin synthesis. So the DPP-4 inhibitors reduce fasting and postprandial glucose concentrations. By inhibiting the enzyme that is responsible for incretin breakdown, that decreases your glucose concentrations. Adverse effects, most common adverse effect is a upper respiratory tract infection, headache, and diarrhea. There have been cases of... Yes, Natalie, I give you permission, but only in front of me. Okay. Pancreatitis has been reported also in these medications. Contraindicated in a patient with a known drug allergy. Yes, Veronica. And that is why they are not a first line. So yeah, they will tend to be not a first line. And if you try, say, biguanide and a sulfonylurea and lifestyle changes and you don't get a good effect, you may actually potentially just go to insulin. Although sometimes, a lot of times the side effects may diminish after continued use. So like with metformin, it can take a couple of weeks for the side effects to go away, but they will. So it just kind of depends. So DPP-4 inhibitors, sitagliptin can increase digoxin levels. If you're using with sulfonylureas or insulin, that might increase your risk for hypoglycemia. And rifampin may also decrease the efficacy of linagliptin. Injectables, you have amylin agonists, Simlin, or the incretin mimetics, Byetta and Victoza. Total side note, Byetta is actually developed from the spit of Gila monsters. Amylin mimics the natural amylin hormone. Amylin secreted by beta cells in response to food, and it decreases postprandial plasma glucose by slowing gastric emptying, suppressing glucagon secretion and hepatic glucose production, and increases satiety, so that sense of having eaten enough, like I'm full. When it's given before meals, it mimics the action of amylin. Indications, it's available, so pramlintide is the only amylin. It's available sub-Q, and it can be used in patients with type 1 or 2 receiving mealtime insulin who failed to achieve optimal glucose control. And this is actually the first medication that was actually approved since insulin was discovered. It is contraindicated in patients with gastroparesis or those taking any medications that affect GI motility. And you need to be careful in patients who are taking any insulin, because mixed with the amylin agonist, you may end up causing hypoglycemia. Incretin mimetics, they mimic mimetic incretin hormones. And they're released by the GI tract in response to food. They stimulate insulin secretion, reduce postprandial glucagon production, slow gastric emptying, and increase that feeling of fullness. Most important incretin hormones are GLP-1, so glucagon-like peptide 1, and gastric inhibitory peptide, or GIP. Indications available only sub-Q. Indicated for patients with type 2 who are unable to achieve glucose control with metformin, asulfonylurea, and or glitazone. Best when given 60 minutes before a meal. Some are actually only once a week, or some are daily. Contraindicated, of course, in anyone who's hypersensitive to the medication, family history of medullary thyroid cancer, and patients with multiple endocrine neoplasia. I feel like a commercial. It can delay absorption of other oral medications because it slows gastric emptying. And if patients are on sulfonylurea, they might need to decrease the dose of that one. Then side effects: amylin agonist, nausea, vomiting, anorexia, or headache. And the incretin mimetics, again, nausea, vomiting. Rare cases of hemorrhagic or necrotizing pancreatitis. Oh, doesn't that sound lovely? And weight loss. Now, with the incretin mimetics, there's also a black box warning, which is a major safety alert. for the risk of developing thyroid C cell tumors. So that's also something to be aware of. Also with the incretin mimetics, patients can experience about 5 to 10 pounds of weight loss. Sodium glucose cotransporters, SGL2 inhibitors, inhibit SGL2, leads to decrease in glucose. SGLTs transport sodium and glucose into cells using the sodium potassium pumps, and that's 90% of glucose reabsorption. So inhibition of SGL2 decreases blood glucose because there's an increase in renal glucose excretion. So the kidneys are excreting more. There are quite a few. They may also increase insulin sensitivity. Quite a few out there. So we're thinking Invokana, which has actually been taken off the market. Farxiga and Jardiance are 3 indicated for type 2 diabetes, monotherapy or in combination. Other effects, they may increase insulin sensitivity and glucose uptakes in the muscles, resulting in improved glycemic control. Contraindicated in DKA and moderate to severe kidney disease. Adverse effects, genital yeast infections, urinary tract infections, and increased urination. It can interact with rifampin and, of course, cause hypoglycemia with other anti-diabetic medications. Hypoglycemia is when you have a blood glucose below 70. Mild cases, you can give them something to eat. Higher, more severe cases, you need to actually give them more. So early hypoglycemia can be confusion, irritability, tremor, sweating. Late hypothermia, so their temperature drops, seizures, coma, or death if it's not treated. The brain needs a constant amount of glucose, so not enough glucose doesn't help. So glucose elevating drugs, you've got oral glucose, which are buccal tablets or gel, or 50% dextrose in water, D50W. That's commonly given injection through an IV. And then, of course, glucagon is the natural hormone. We've talked about it. If you give a glucagon sub-Q, that may induce vomiting. So with glucagon, you're going to want to roll the patient, an unconscious patient, on their side before you give them the injection so that if they do vomit, they don't aspirate the vomit into their lungs. Implications, obviously you want to throw a history, vital signs, you want a blood glucose level, A1C, you may not always have that in the hospital, and look for any complications or drug interactions. For instance, steroids or corticosteroids actually will increase blood glucose, so you may want to be aware if the patient's on any of those. Before giving drugs, assess patient's ability to eat. Assess for any nausea or vomiting, because hypoglycemia. If they're NPO, make sure you clarify if they're supposed to have any anti-diabetic meds. Overall concerns for any patient increase when the patient is under stress, because that increases glucose, has an infection because they need to be more maintained, an illness or trauma, and then, of course, pregnancy and lactating. So patient with type 1 admitted with an acute exacerbation of COPD. He's on IV antibiotics, nebulizer, albuterol, and an IV corticosteroid. He's also taking a proton pump inhibitor for gastroesophageal reflux. He takes a dose of glargine insulin every morning. This evening, the nurse notes that his blood glucose level is 170. The next morning, his fasting level is 202. What is the most likely cause of his elevated glucose? A, albuterol, B, the antibiotics, C, the proton pump inhibitor, or D, the corticosteroid? Absolutely, guys. It is D. But like I literally just said, corticosteroids can increase glucose levels. So be aware of that with your patients. And you're going to see steroids a lot with people with COPD. Thorough patient education. You want to teach them about their disease process, what's going on with them, diet and exercise recommendations, self-administration of insulin or oral drugs. You may have them do a return demonstration. You also might have them demonstrate how to do their own finger sticks, and then monitor for any potential complications. I recommend the American Diabetes Association website for patient education material, and that is diabetes.org. So insulin, course correct route, correct type, correct time, and correct dose. Second check with another nurse. Check blood sugar before you give insulin. Roll the vials instead of shaking if you have to mix. Make sure they're stored properly. Use only insulin syringes. And ensure correct timing of insulin dose with meals. So make sure that the patient is eating or going to eat any minute now. You're going to give a sub-Q injection at 90-degree angle unless the patient is emaciated or extremely thin. In that case, you might give 45-degree angle. Drawing up 2 types, we talk about the regular or rapid, clear to cloudy. Make sure you provide education. It's one of the 10 rights. Regarding the medication, monitoring blood glucose, injection site rotation, very important. Excuse me. After the 0700 report, the day shift nurse notices that a patient has an 0730 dose of insulin, excuse me, and goes to the automated dispensing machine or Pyxis. And the nurse sees that the night nurse removed that insulin dose, but the medication record has not been signed. The patient is confused and says she thinks the night nurse gave her the insulin. The patient's blood glucose is 142. What will the day shift nurse do? A, give the insulin because it was not signed off. B, hold it because the patient thinks she received it and it is recorded in the machine. C, ask the charge nurse to call the night nurse at home to clarify. Or D, report this to the nursing supervisor. Absolutely. Good job, guys. You're going to have the charge nurse call and see if you can find out if the patient was actually given the insulin. Okay. So you need to make sure, was it given or was it not given? Oral antidiabetics, always check blood glucose before giving. In the hospital, usually you're doing that in the morning. Sometimes you might do an evening one, but they might just have once a day glucose checks. Usually give about 30 minutes before meals when you can. The alpha glucidase inhibitors should be given with the first bite of their main meal. Metformin is taken with meals. It helps reduce the GI side effects. And again, we talked about the contrast dyes because of problems with the kidneys. So you might have to check with the prescriber. Always keep in mind hypoglycemia. Follow any protocols that are in order. So give oral glucose if the patient is conscious. So glucose tablets or gel, corn syrup, honey. I had a cat that was diabetic, and if we saw symptoms of low blood sugar, we took a little Caro syrup and put it in his mouth, and he absorbed it. It absorbed very quickly. You may have to give D50W or glucagon IV if the patient's unconscious, and then continue monitoring for a little while. And then monitor for therapeutic response. You're going to, obviously, therapeutic response is going to be lower blood glucose levels. The provider might be doing A1C testing, so they'll be monitoring that. And then also any hypo or hyperglycemia. You're going to monitor for any of those symptoms. All right, guys. So that is it. We actually got through the everything. Sorry we ran a couple minutes over, but I think it takes a little bit longer to do the test because you got to log into Respondus and then you got to get into the test. So that's delaying us a little bit. So I had to speed up some. Any questions, guys? All right, like I said, I uploaded the a worksheet into the chat. Of course, you can't see it with my nifty little thing. I haven't seen that email yet, Isabel. The returning to campus is occurring. I do know is going to occur in multiple phases if we when we return. So that might be where it's coming from. They had discussed it with us. But there's like a first phase, and then it's gonna be a very slow process and very careful process. So no, we're not returning to campus next week. Like full on, everybody's there. Oh, speaking of next week, thank you, Belle, for reminding me. Remember, next Monday is a holiday, guys. You get a 3-day weekend, so to speak, at least from me. And then, so we will be actually having our makeup class a week from Wednesday. Tomorrow's exam, you're going to get in, I think it's over 50 minutes. What CUSIN presentation are you talking about, Jessica? Mercedes, I shared into the actual chat. If you scroll up, it's just a practice worksheet. Yes, Veronica, that's correct. Makeup is Wednesday, May 27th, same time. Lot. Trying to figure out what you guys are talking about specifically, because I don't really lock anything, but let me make sure. No.
On the Canvas, it says there's a CUSIN presentation due. It's like lecture 12, week 6 or something like that.
Okay, so that's fundamentals?
Yeah.
We'll talk about that tomorrow.
For the case study, that's due on Sunday
by midnight.
Okay. So hold on, where am I at? The 30th? No. The 30th? 31st. Correct?
No. This Sunday.
This Sunday. Okay.
No. I'm not sure why it's locked, you guys. That is weird. I cannot figure out how the homework is locked. Because I know some of you have. Oh, yes, Courtney, thank you for reminding me. Okay, guys. So the confusion should be over. Math is truly, this one I haven't had any, this has not changed. Everything's completely the same. So if it's confusing you that I put in a placeholder, like in week 3, I put in that the case study is, and it's due week 6, and the due date is June 1st. So if you scroll to week 6, you see case study June 1st. That is when the case study is due. So I am literally in week 4 and I cannot see where anything is closed. I think June 1st, isn't that a Sunday? Oh no, I'm giving you till that Monday. There you go. You're welcome. I'm still not sure what's locked though, guys. I've been into everything. The readings, the homework. I can't figure out what's showing up as locked. And then there was another question I wanted to answer. Probably internet issues. Let's see. What was the other one I wanted to answer? Oh, the poll. Courtney, thank you. Yes, so the poll. So guys, in fundamentals, I put up a poll or survey. So I wanted you guys to do that. Most of you have, but a few of you have not yet. The rationale is as we open up, we're going to be doing a very slow open. And so we're going to start bringing in very small groups to do skills. And since we're going to be starting clinical simulation in a few weeks, I wanted to try and get the people who have had zero experience, like never taken a vital sign in your entire life, don't have a clue how to do any kind of assessment, like using your stethoscope or any of that. I wanted to bring those people onto campus first. So that is the purpose of the poll or the survey. So if you have not done the survey or the poll yet, please do so. And then that also gives me an idea. The reason why I was looking at how long you've been in that job or in the medical field gives me an idea about who has the most experience. So maybe I don't want to put a more experienced person with someone who's inexperienced. And also I may not have to worry about you as much. So that's why I need the poll completed. And for those who haven't done it, where is it? Oh, yes, it's in week 4. Under lecture 8 at the very bottom of week 4, it's skills lab poll. So another thing I want to say, guys, is that I get it. You have me for both classes, so it's easy to kind of cross-talk about 2 classes. But let's try to keep it focused to the class we're in. That was my confusion earlier, so I apologize. But and I know it's easy to be like, well, I have her here. Why don't I ask? So let's try and do that as much as possible because it just makes it easier and that everybody's always on the same page. Because I'm sitting here thinking about Pharm, and then you guys are thinking about fundamentals. So the link for the poll is under week 4 at the very bottom in fundamentals. That's the only time I'm going to do that. Any other questions, guys? Oh, and for anyone, you should all have your papers in. But if you had issues loading it, some of you asked for, and here I go doing what I said we shouldn't do. For fundamentals, it needed to be loaded under lecture 6. So. Okay. Y'all got quiet on me. You're welcome. You're welcome. So again, remember guys, 3-day weekend. Yay, you get a 3-day break from me after Thursday. Actually, 4 days then. So, all right, guys, have a great evening and I'll see you guys tomorrow morning. And normally I would stay and wait to see if there's any questions as people log out. Okay. Jolyn, was it through Teams? Okay. Yes, I got your email, Davina. So, and I will go back and look at those. Probably won't be till like Wednesday or maybe tomorrow afternoon. All right, guys. Like I said, normally I would stay, but I actually have a 3:30 meeting. You're welcome. So glad we got through all that with everybody. So I will see you guys in the morning. Again, you can still message me through the chat or you can just shoot me an email. I'm still working and while I'm doing my meeting, but it's supposed to be a long meeting. So I might get some more information today about returning to campus. So I will let you guys know as soon as I know. See y'all later.